No. Are you
Lemon,
Dr. Aditi?
Soma.
Dr. Aditi?
Yes, sir. Sir, I would take over this.
Yes,
So,
that's why I am
generally,
calling you. Right.
so sometimes we have that if the color is more like a lemon yellow or an orange, it goes towards more unconjugated.
Unconjugated. Right.
Else if it becomes more greenish or gives a tinge of green, Soma, we will think more of conjugated type of a jaundice.
So this baby is more likely to have greenish yellow tinge
Greenish
rather than
tinge.
orange tinge, which you are describing.
So,
Right.
Soma, from your history, can you say whether it's a conjugated hyperbilirubinemia or unconjugated? What are the pointers from the history?
Sir, ma'am, from the history, since she was passing high colored urine, so predominantly it was a conjugated bilirubin which she was excreting in urine. Also,
I just want one more thing. Is just high colored important, or what is more important then? Because all the urine.
staining
Exactly.
of diapers.
Exactly.
Yes, diaper. Okay. So
yeah, if it is conjugated, then where is the level of obstruction from the history? Can you have some more clues from the history itself is my question.
Yes,
Okay,
yes.
let me make my question further, making simplified to the student. Okay, what kind of history you would get in intrahepatic cholestasis, and what kind of history you will get in an extrahepatic cholestasis, like let us say choledochal cyst?
Sir, in choledochal cyst, there can be the child may intermittently pass pale colored or intermittently pass pigmented stool, sir.
And why do you get intermittent in
Waxing waning
choledochal cyst?
courses, sir.
Huh?
There can be periods of waxing waning courses, sir.
Why?
Sir wants to ask what happens during pale stools. So
Yes.
so sir wants to know why suddenly
Why it is intermittently pale and yellow?
Pale.
So why it changes? See,
So
many of us are under impression that extrahepatic stasis is because of obstruction, but generally I heard from one of the pediatric surgeon, ma'am, Aditi, you can correct me. He was telling me that the size of the cyst can be so large that there can be kinking of the extrahepatic biliary tract, intermittently. That means as and when there is a movement, suddenly there can be obstruction because of not necessarily an obstruction, but even the key where the very kinking can many a times cause obstruction. Madam, your comments on that, please.
So true, sir. So all extra, sir, you want to elaborate whether extra hepatic obstruction, how it has to be differentiated from parenchymal causes of jaundice. So, sir, because we deal predominantly with biliary atresia and choledochal cyst. So one good point, Soma, you said that biliary atresia will have a persistent jaundice, progressively increasing, whereas a choledochal may give a history of waxing waning. Well, sir wants to say why waxing. So, sir, I think component of both the things, as the size is enlarging, it can compress the choledochal cyst. Second is formation of sludge within the choledochal cyst. So those sludges can cause absolute blockage and cause a feature of cholangitis intermittently. So whenever this child will have, they can also have a pale stool, sir.
My question is that in such cases of, as a gastroenterologist, when you have an extrahepatic obstruction, is it exclusively extrahepatic or will there be an intrahepatic component as well? Please.
So very well asked question, sir. So the extrahepatic biliary atresia is a misnomer now. So and similarly for choledochal cyst, we now say congenital malformation of the hepatic and the biliary system, because these all diseases, they may have main problem in the biliary channel, but their progression leads to involvement of the liver as well. So we cannot isolate the liver and the
it's more a spectrum than a watertight compartment. That's exactly what you meant by. Beta, I got some knowledge. Thank you very much for bringing Aditi in. You can go ahead.
Thank you, sir.
Dr. Soma, what is the cause, sir? Which pigment causes staining of the diaper? Simple question, but still for awareness of everyone.
Soma, are you there?
Yes, ma'am.
Sir wants to ask what caused staining? What is the part of the
which component of
which component? So what are the components in the urine which causes yellowing generally? What do you think, Soma? Could be a bile?
Bile acids which are...
So what are there? Bile acids. What else are there?
Bile acids and bile salts, ma'am. And mainly stercobilinogen can cause. Stercobilinogen,
No, it is in the urine, urobilinogen. You see, in the urine, urobilinogen. Okay.
Yes, sir. And in stools, it is stercobilinogen.
Okay.
Soma, can
What
you
do you
tell
mean
some?
by, what's your understanding of telling intermittent oil in the stools? What do you mean by that? Just elaborate it.
Intermittent oil can be because of fat malabsorptions, which
Is
can
it oil? You would like to call it as oil?
sir oily, which
Greasy
is
stools.
difficult
Okay,
to greasy stools, which is difficult to flush, sir.
Greasy stools.
Sir is
Then
right.
oily.
It would be more like a greasy stool.
Greasy
Shiny,
stools.
greasy
Okay.
stools.
Okay, sir.
Soma, can you tell what are the hemolytic anemias which can present with jaundice at this age?
Hereditary spherocytosis can at 6 months can present. Thalassemia also can present at this age.
Right. Beta thalassemia major. You say not simply thalassemia. Beta thalassemia major. Not all thalassemias. And secondly, how many types of bilirubins you know?
Conjugated and unconjugated bilirubins.
No. You shall be much more than under the guidance of Dr. Aditi.
So
Right? There are 4 types. You know, there are 4 types. Just you try to tell what are the 4 types of bilirubin that you have.
so many idea bound and
Okay, unconjugated.
unconjugated, conjugated.
Type 1 is unconjugated, tightly bound to albumin. The
Okay.
second one is
Oh, not
unconjugated, not tightly bound. That is the cause for kernicterus. Crosses the blood-brain barrier in the newborn period. Then conjugated. 4th one is delta variety. Delta variety is significant. In your case, the delta component is significant because that is the one which continues the icterus in the body when there is conjugate hyperbilirubinemia. Am I clear? That is the component which makes the icterus persistent for longer time when there is conjugated hyperbilirubinemia. In this context, I ask. Okay, right. Next. And you would like to ask anything else. History of presenting illness is very important. See, your negative history is very good. And you are telling the causes, that's wonderful. Anything else in the history? See, on physical exam, there may not be much in this case. Isn't it?
But we have detailed the history in family and other developmental history.
No. That is there,
Just
ma'am.
a presenting complaint, sir.
Okay. And see, you have to analyze the complaint fully.
Okay, sir.
History of fever. Is there any relevance in asking for history of fever in this infant, Dr. Soma?
History of sir, if there is a history of fever and the child is sick looking, it may be because of sepsis due to galactosemia, or it can be if the or it can be due to underlying sepsis, or if it is E. coli, it can be because of galactosemia, or it can be because of
fever. Galactosemia nothing to do with fever, you know. And this high grade fever, the child is very toxic. What does it suggest?
So Soma wants to ask whether sepsis could be a possibility.
Sepsis is, telling sepsis is a possibility which can cause cholestasis, sir.
Right.
What about
cholangitis? Cholangitis is one thing which you have to assess. So history of fever is also important. I understand for such a 3 months long history, you don't expect it to be because of sepsis or because of cholangitis, but for completion's sake, you may ask. At least in the initial phase, was there any history of fever? Yes, Garian, we will go ahead.
True, sir. Thank you.
Right. Your negative history is very good, and mentioning the causes is also much more informative. Good.
Thank you, sir. Regarding birth history, antenatal history, there was no history of maternal fever with rash. There was no maternal history of itching, jaundice, or thyroid disease. There was no history of pregnancy-induced hypertension or health syndrome. No history. All the antenatal ultrasounds were normal. As per natal history, she was a first order infant, term gestation, born out by normal vaginal delivery with a birth weight of 2.75 kg, appropriate for the gestational age. She cried immediately after birth and she was breastfed within 1 hour. Regarding postnatal history, there was no history of neonatal jaundice or seizures or in ICU admission or history of phototherapy. Regarding family history, she was born out of third degree consanguinity. There was no history of repeated fetal loss or early demise. There was no history of blood transfusions in family or any kind of liver disease in parents or siblings.
How did you ask for the history of liver disease in the family?
Ma'am, I asked whether there was any history of jaundice or similar presentation in the family,
Anything else?
or any bleeding manifestations or history of itching in mother in second and third trimesters.
Okay, only in the mother. If it's PFIC, what all other history you can ask? Just in the mother, or you can ask even?
We can ask the history of jaundice in siblings, ma'am.
Now, why only jaundice? In chronic liver diseases, you may just get abdominal distension.
Distension and
So that is important, because more, see, if you take liver diseases, chronic liver disease as a spectrum, a small number of them have jaundice, but large number of them are without jaundice.
Yes, yes.
I don't know. That's the point, because liver disease is often missed because of this presentation. You agree?
So you're right, sir. So in fact, Soma, we should ask whether there was history of any bleed, any requirement for ascites, any history of early death because of, so jaundice may not be evident always.
And pruritus in which trimester, Soma, you expect?
Third trimester, ma'am.
Yes. Okay. Continue.
Soma, after family history.
After family history, I will
Just a minute.
developmental.
Yes, yes, carry on.
Regarding gross motor, the infant has achieved head control at 4 months of age. She bidextrous grasp was noted. Regarding socio-adaptive, no stranger anxiety noted, and she was able to speak monosyllables. So as per the developmental history, her developmental milestones has been achieved as per age.
I wanted to compliment you that you are telling very positives about the history. Unlike many postgraduates whom say that child cannot walk, child cannot run, child cannot skip. You are very positive in telling what the child can do. I'm telling you, you are surely going to get gold medal. Yeah, it's very nice of you. I'm telling you a compliment, but it's not related to the case, but very nice approach from you.
Thank you, sir. Regarding nutritional history, she was exclusively breastfed for the initial 5 months, and 1 month before the admission, mixed feeding was started. But there was no exposure to sugar or honey, and there was no history of use of copper vessels.
May not be relevant, copper vessels.
Yes, sir.
Just 1 month only the baby was having from something from outside, isn't it? May not be relevant. Okay.
Right, sir.
No, but you must explore what is the reason for mixed feeds. Is it just that the mother started giving mixed feeds, or she felt that something can cure some illness in the child as advised? See, and what was that was mixed in the feeds? These are very, very important, because that they will speak of some kind of intervention. Is it just the change in the nutrition, or is it an intervention nutrition that the mother is thinking? This is important for us.
Sir, because her breast milk was not adequate, so she started formula feeds for the last 1 month, sir.
Agreed. Now, is there something that can be mixed in the feeds that can be hepatotoxic?
If there are some sugar or honey, it can be hepatotoxic in case of hereditary fructose intolerance, sir. The child may develop aversion.
Sir, also want to know whether any preparation like medication, alternative
medications, alternative systems of medicine, heavy metals.
India,
and
we
there
have
are
a lot of indigenous.
lot of indigenous things. So that's why in some areas there are some peculiar things that are hepatotoxic, and a PG, a postgraduate should know which are the elements that are prevailing in the local ethnic areas that can be hepatotoxic. Very, very important, because you will never know the importance of them unless the child gets into problems.
Okay.
Also, so I just want to know how the child has been for the past 3 months. What about the growth?
Growth was he was gaining.
Was the child well throughout the 3 months, playing well, activity? Because this is a chronic illness now.
Yes.
So we would like to know what about the activity of the child, the growth of the child, appetite. You should have mentioned that in your. I just forgot to tell you. Should have mentioned that in your presenting illness.
Ma'am, the child was active and he was taking feeds. There was no, his appetite was totally normal, ma'am. She was a well thriving child.
Despite jaundice, the child was thriving well,
Yes,
eating
ma'am.
well.
Yes, ma'am.
And you should defend like a lawyer, you know, the very fact that the mother did not do anything for 5 months and exclusively breastfed. That means she was happy with the child. Otherwise, they will do something in between that the child is not gaining weight. They'll start giving artificial feeds, etc. At least
Yes,
for full 5 months, exclusive breastfeeding itself will tell you that the growth was good. Correct?
yeah,
No?
yes.
But not necessarily, but that's an indirect point.
Did the mother notice any kind of abdominal distension?
No, ma'am.
No.
Okay.
Why
No,
it is relevant is you have to ask about all other GI symptoms that can occur whenever there is some GI symptom, like vomitings, abdominal
Vomiting.
distension, any
Yes.
altered stools. See, you ask any related symptoms also, right?
Okay, sir.
There was no abdominal distension, is it?
No, sir.
No,
No
No
history of
abdominal.
vomitings. No history of vomitings.
No history of vomiting, sir.
No
Intermediate
dark color
stage,
stools.
that was not significant, sir.
Right. No dark color stools also.
No dark color stools, sir.
If there is dark stool, what is your take?
It can be because of melena, sir. Maybe there is some upper GI bleed is ongoing because of development of varices secondary to portal hypertension.
Do you expect
Or maybe
hypertension
because
to
of
affect?
iron syrup
So,
also it can happen,
And
sir.
also, Soma, what you have considered as the first most common cause of
Bleeding.
coagulopathy or bleeding would be in a
no,
child.
she has.
Vitamin K deficiency
You
can
have
be
already
there, sir, because
answered
of
it. Right.
Aditi,
It is not the
Aditi, I wanted
varices. It
to
is not the varices.
Aditi,
Don't worry about
Aditi, madam.
varices. There is
Aditi, madam, I
hepatocellular
wanted
injury.
your opinion on one of these. We pediatricians start asking histories in the mother now. How good they are in interpreting the colors. We ask the color of the urine, they say fine, but when we see it is red, and when it is red, they either overplay or underplay urine and stool. Aditi, ma'am, when in your gastroenterology practice, how often the version of the parent and the color blindness or color fineness that we have got in our brain matches?
Sir, first of all, I would please don't embarrass me by calling madam. I'm just Aditi.
Okay, fine, better. Tell me. Go
And
ahead.
second thing, sir, so what your question is so relevant. I can't tell you. There are papers on this also. So what parents perceive, what doctors perceive, and why there is an importance of stool chart. And Soma will present this in her subsequent presentation. That how one stool color can be misperceived, and that's why there's a protocol that we should always inspect, and it should be inspected by an experienced physician, because there is a mismatch. So 60% of the parents, this is a fact, that misperceive the stool color. So
And
the
Aditi,
most
is it like
common
that?
cause of
Aditi, is it
bleeding.
like that? You should see the stool by yourself for at least 3 days.
Right, sir. So the protocol
So
so
in
we will
that
be
case,
presenting. So the guidelines say
Aditi,
3 stools. Yes,
yeah,
sir.
in that case, conversely, if we analyze, somebody telling not passing pale stool, how
So we will
often it
not
is
believe them.
reliable? It may not be reliable, you know, there
It will
could be
not be
pale stools
believable.
and they
True,
may
sir.
not tell the history of pale stools. So PG is telling I have ruled out that by just because there is something white, yellow, etc. is something that they should not do. If they can rule in, it is excellent, but they should not rule it out. Do you agree?
Definitely agree 100%.
Right. Dr. Soma, whenever there is jaundice for such a long period of 3 months, there may be, even though there are suggestions of cholestasis, there can be some hepatocellular injury also. You have to ask for symptoms pertaining to synthetic function of the liver. Okay, that is very important. The most important synthetic function that may be affected in short duration is
Vitamin K production can be affected,
dependent
sir.
clotting factors.
Yes,
Then
sir.
over time, it is the albumin. Okay, don't worry much about the excretory function. You focus on the synthetic function, right? When it is a prolonged one, jaundice, right?
So we missed on to our these complications. So we should have added Soma about vomiting, diarrhea, and the complications
Right.
like ascites and bleeding.
Ascites, yes.
Right. Yes, Iskarian.
Regarding immunization history, BCG scar was present in the left upper arm. EC was immunized as per national immunization schedule. The last vaccine was taken at 4 months. She has received third dose of Penta, OPV, Rota, second dose of IPV and PCV. So based on our history, I want to summarize the whole thing. So this is an infant.
No, just 1 minute. For the completion sake, you
intervene
would
and
have
ask
mentioned
you-
about socio-economic history. For completion, may not be relevant in the particular case, but
Right.
when you are presenting in the examination, you cover all the headings.
Right, sir.
Yeah, second, Soma, I wanted to ask a question as a postgraduate PG, please answer to me. If some other says yellow infant very early, will you or will you not give a hepatitis B vaccine? Will you do HBsAg and then give an hepatitis B vaccine? Please, this is important for us.
Sir,
Hepatitis B, I'm telling as a part of routine immunization schedule. Got the point, no?
yes, sir.
Somebody says that 4 weeks child is looking yellow. Will you go ahead and give it DPT plus hepatitis B everything, or will you hold on hepatitis B, or what is your plan?
Sir, if she or he has taken hepatitis B as in routine immunization, then we will not repeat, sir.
No, no. Suppose you want to give, will you give or will you not give?
No, just
We
you
can
think or
give,
you'll
sir.
get the answer, right?
We can give, sir.
No, not can.
You can give. Is there a
You
reason
are-
not to give, or is there full evidence to give? It is other way around. You should be very clear on what is your thought process on hepatitis B immunization as such. Is it related to jaundice or not related to jaundice? First of
I
all,
wants to ask Soma whether hepatitis B causes jaundice.
yes, it is other way around.
Immunization.
Okay.
It will, at such a small age, it will not cause, sir, much jaundice.
It's a hepatitis
Small
B
age.
leading to icterus takes long years, not in few months or days. Okay.
Yes,
Right.
sir.
Okay.
So I want to summarize the whole history. This is a infant presented to us with cholestasis with pigmented oily stools of 3-month duration with history of 3rd degree consanguinity with normal neonatal course with normal development and immunization history and without failure to thrive. So based on our history, we kept these as our most common differentials. In structural, we have kept choledochal cyst because in choledochal cyst, they will have cholestatic jaundice as in our case with pigmented stools. But the point which was against was that there was no lump or abdominal distension noticed by the mother. And one of the other possibilities we kept was biliary atresia because it is the most common cause of cholestasis. And sometimes the parents may misperceive pale stools as pigmented stools, and the child is a well thriving child. But since the child was apparently normal for the first 3 months, there was no features of abdominal distensions or no features of decompensation. So this was a point, though no history of pale stools or no history of high colored urine. So this was a point against biliary atresia.
Do you think, just 1 minute, do you think that stones will manifest like this at this early age?
Yes, sir.
Which condition may lead to stones in the CBD?
Hemolytic jaundice can present with stones in this age also it can present, sir.
Which hemolytic anemia?
Hereditary spherocytosis can
Even
present.
that also CB stones may be too early. Dr. Aditi?
Right, sir. Maybe incidence wise, if we see, it is not very common, but rarely presentation of structural causes. We have choledochal CBD stones. So if we keeping the possibility, because the first 3 months there was no jaundice, then we thought a choledochal cyst would come definitely first, sir.
I just want to ask Aditi whether biliary atresia we would like to consider on top when the jaundice is started so late, 3 months.
So actually, ma'am, this is just history based.
Yes, that's
right. So I want to tell the audience, if the patient comes to us, we first have to rule out the most common and the most treatable cause.
That is biliary atresia.
Aditi, I wanted to just ask you a couple of questions related to, hepatobiliary movements, stasis and stone. Please give some cause or effect of dysmotility? Number one. Number two, it is other way around. If there is a stone, is it that the presence of stone causes obstruction and therefore stasis, or is there a pre-existing stasis and then there is formation of stone? It can be both the ways, and therefore kindly comment on this. Like we have intestinal dyskinesia kind of things, do we have some kinetic problems even in the hepatobiliary tree?
So, sir, when we read the chapter on stones, especially gallbladder stones, so the pathogenesis says that stones is because of a triad of three things. It is a motility issues, which is called as a dyskinesia or a dysmotility. Second, there is a predisposing factor, or there is a hypercoagulable sludge forming state. So either the cholesterol is more, or there is more pigments. And third thing, there is infection. So any cholangitis, any bacteria, and combination of these three things would lead to formation of a stone in any individual. Now, the predisposition decides which child will develop a stone early or late.
No, if we narrow down to this child, what are the likely things, ma'am?
Sir, Aditi, sir, I would say, sir.
Okay, next slide she can show probably.
Yeah, it is
coming
like
up with
higher up.
more slides.
Anyway, we'll go ahead. No issue.
Sir, they are coming with more slides.
Carry on, Sama.
So the other differentials we kept were genetic causes like a familial intrahepatic cholestasis, bile acid synthetic defects, and Alagili syndrome. Because the child was passing oily greasy stools, as well as the stools were pigmented, and the child was predominantly having cholestatic jaundice pattern. The points which was not favoring genetic causes where there was no history of any pruritus and there was no extra hepatic manifestations. Similarly, there is a list of metabolic causes which we have kept.
Just 1 minute. When we are talking about Alagili syndrome, we would like to see the image of the child. Do you have the picture of this child?
No,
Yes,
she's
sir.
still in the history, sir.
You may
She's
show.
still in the history.
Right, sir.
Yes, sir.
She's still in the history. We'll see it on the examination.